Ladies and gentlemen, thank you for the invitation. It's always a pleasure to be with a dermatologist because I strongly believe that scar treatment is a treatment which has to be done together, dermatology and plastic surgery, and the better we work together, the better our results are. Now, C-section is a very important topic because it's at least the second most important scar in my scar treatment experience, with the acne being the most important. There is C-sections different amount in the world, and in the country where we are now, in the Arabic countries, about 40% of women nowadays have a C-section. Now, if for C-section, as for all the scars, you have to judge or fix some criteria. You want to judge what are the patient's complaint and what is the goal of treatment. And I think the color, redness, pigmentation, volume, dysesthesia, haptics, appearance, and even some psychological aspects, please do not forget those too. And based on those aspects, on your judgment, you know there's so many classifications of what is an adequate scar. But there can be a very simple one. This is the inadequate scar, that is the annoying scar. Patient is annoyed, is the acceptable scar, but there is some disruption, and there is the inconspicuous scar. Now, my talk consists about two parts. One, I want to debunk with the two most obvious myths in scar treatment, and then I want to give you my approach to the scar treatment of the C-section. Now, the first is, and this I'm hearing even nowadays from a lot of my colleagues, call the plastic surgeon, I do not want to have a scar. Well, whether a plastic surgeon is doing the scar or not, wound healing is scar healing. This is not tissue regeneration because the tissue is replaced by uniform scar tissue. So this is a thing you have to tell the patient. We can make a scar less noticeable, but there will always be a scar. And the second and even more important myth is that the patient is coming to see you and say, doctor, I cannot do anything to improve my scar. Wrong. As long as the scar is red, you can do very simple things to significantly improve the scar appearance, and I will show you this in a minute when we talk about the scar suppressive leather. Second part is how to treat now those C-sections. And to make it simple for an educational purpose, you can divide the scars according to the age to the young, active, and red scar, and opposed to the old, white, inactive scar. So when it comes to the young, red, active scar, you have the chance of working on the scar, and this period is called the scar suppression. You know that the end of skin closure is the beginning of remodeling phase, and this remodeling phase takes between 3, 6, 12, 18 months, depending on the age and on the genetic factors of the patient. And I think it's very, very easy to have a look on this scar suppressive leather, because those are the simple things the patient can do on a daily basis herself to significantly improve the scar pattern. Now, this is less for you, I suppose, but this is for us surgeons. We do not think about the basic skin care. We have no idea that a dressing or a garment is a very aggressive thing for a scar, and there needs to be a good basic skin care, because the quality and the moisture condition of the skin has an important impact on the scar formation pattern. The next thing is scar massage, and there are a lot of myths too. It is the massage that is important. It is not the cream. As long as you can make a massage without irritating your skin too much, so you have some fatty cream, use whatever you want, but there is no such as a scar cream. And there is no place for the Dermatix gel, silicone gel, as I will show you. What are the goals of the scar massage? The first goal of scar massage is to make a scar less sensitive. If you ask a patient right after surgery, they do not want to touch the scar because the scar is very sensitive. And this is the first week they will desensibilize the scar. The second and the third is to reduce the redness, to reduce the volume, and the very important thing is to increase the mobility. So to restore the gliding pattern of the subcutaneous muscle interval. Very important too is the edema management. We know that the better we treat edema, the more are speeding up for wound healing and scar maturation. A cornerstone is the silicone sheet, and it's the thickness of the silicone sheet that's important, and that is the reason why the silicone gel has virtually no indication. It's very expensive and has no effect. We can discuss on that, but that is the essence of 20 years of burn research. Now, what makes a difference is the combination of techniques, and one very common for us is the combination of the silicone sheeting with a compression garment. And we know that the effect of combination is not only the double, but is multiple. It's much more about if you combine the silicone sheeting and the compression garment, it's about a 7 times higher effect than with the silicone alone. At the end of this scar suppressive ladder, there is the laser. Well, laser is used, in my opinion, too often, too early. Just if you treat the redness, you can treat different things with different lasers, understood, but speaking about the redness, you should wait long enough, and I think this is a consensus with dermatology too. Now for the old scar, an old inactive white scar needs to have some corrections. And again, you need to make an analysis. What is really bothering the patient? Is it color? Is it haptics? Is it volume, dysesthesia? Or is it the appearance? Or is it a combination of all? If you take down the scar, very often there is a second chance. This is the message to the gynecologist. Do it better the second time. And if you do a scar revision, there are 4 points you have to watch out. Very often the scar is inadequate because it is not parallel to the skin lines. It is crucial to know about the longer skin lines or the relaxed skin lines, because the more parallel you are to those lines, the less tension you have on your scar and the less likely you have to have a hypertrophic scar. Now, you should cut down the scar completely down to fascia, and then you have to mobilize both tissues, because very often there is a limitation of motion, and that makes the overhang of a scar or of the apron and the abdomen. And then you have to suture the scar in an adequate way, so you do not try to bring the least possible amount of suture material at the dermal epidermal junction. And you work on the upper dermis, but you try not to touch the dermis. That is a little bit the principle you should do. If you do those atraumatic, tension-free, adequate postoperative care, basic skin care, and preventive scar suppression, so you make an old scar, a new scar, and then you restart with your scar suppressive treatment, then you should come out with a much better result. There were some scars which are good, but the only thing is color. And you cannot cure color with a knife. We try to do some exosomes, we try to do injections of stem cells. For the moment, this is experimental, gives some results in some patients, in other patients does not. But there is one thing, that the scar coverage, and scar coverage, there is the makeup artist or the tattoo artist, or micropigmentation, as you want to call this. And there are two things: even you do a distraction with a tattooing, or you do a discretion with a micropigmentation. The last thing I want to draw your attention to is a scar is not only a physical thing, but also a psychological thing.
I'm sorry, doctor, but your time is over.
Yes, have a minute.
Yeah, sure.
Think about this. If there is a problem associated with a scar, you need to involve the psychologist too. If you use those concepts, those steps, I think you can really improve a big patient group, and I just thank you for your attention.